Okay, let's go ahead and get started. So, Dr. Kofer, if you want to move us forward a little here. Oh, and Dr. Fenton, I think, is jumping on right now.
Oh, perfect timing.
Hey, everybody.
Hey, Dr. Fenton, we're just about to start. So if you want to go ahead and start the introductions.
Awesome. I'd love to. First of all, guys and gals, good evening. I know it's a long worked day, and everyone here appreciates you being on. Really, the impetus of the webinar was to, as your chief clinical officer, was to really the obligation and the desire to keep all of you guys in tune with and have resources available to you as far as innovation, technology, learning pearls, everything that has to do with becoming a better clinician and optimizing your outcomes, right? So when something comes across the table as far as a new gadget or a new piece of workflow, I just want all of our doctors to be able to be in the know and to form their own opinions and to know what resources and tools are available to them. So that's what brings us Dr. Koford this evening. And regardless if you're heavy into fixed now or if you're aspiring to do fixed, you're going to learn something. So without further ado, I want to properly introduce Dr. Koford, who, by the way, is our prosthetic faculty within the affordable curriculum of fixed pros restorations. He teaches two courses for us, one of which is being a provisional restoration of fixed full arch reconstruction, as well as the final restoration. So you can find those on the inside of Affordable website in terms of registration. And you've probably heard me say this many times, and Dr. Koford will likely echo my sentiments as far as implant dentistry being prosthetically driven, right? So from the perspective of the Omni abutment allowing for optimal emergence profile and prosthetic screw positioning, it's really the number one as far as the restoration goes. It's the number one from positioning standpoint, what determines the long-term viability, right, of your final prosthesis. So we're lucky to have him, and I'm excited to present him to you. So let me give him the proper intro here, in which not only is he a KOL and esteemed faculty member for Affordable, he is also in private practice. He is a 2008 graduate of Case Western Reserve University School of Dental Medicine, surgical prosthodontist who completed his residency with the United States Air Force at Lakeland Air Force Base, Wilford Hall Medical Center, McCown Dental Clinic in 2011, as well as earning his master's degree in biology from the University of Texas Health Science Center at San Antonio. He served 6 years with the U.S. Air Force and achieved the rank of major. He has been in private practice in Cary, North Carolina since 2014. He is a partner in 7 dental practices and a full-service dental laboratory as well. In 2018, Dr. Koford and Charles Rusil developed the Smart Denture Conversions separable fastener technology, in which many of you likely use for your provisionals when you immediately load. And that was introduced to the market in 2019. So it is my esteemed pleasure to introduce to you Dr. Brandon Koford. Thanks.
Well, thank you so much, Dr. Fenton, and it is an honor to be with you guys tonight. A lot of you have come through the training programs that I put on, and those are, just the highlight of my month or my year, is to spend time with all you clinicians who just really want to devote yourself to good quality patient care. So it's just honor to be here, and I really appreciate the invitation, Dr. Fenton. I really appreciate your visionary leadership here. Cameron, why don't you go ahead and just go over some housekeeping items and then we'll get into the presentation.
Yeah, so we already talked a little bit about this. Please, like I said before, submit your questions in the Q&A section. We've already had a couple in there. That's great. We do want to get to those, so I don't want to waste time here, but we will also be sending off a recording of the webinar to all registrants. So do look for that in your email. Make sure to check your spam or junk email tomorrow. It should come out tomorrow by the latest, Thursday. But it should be in your inbox here pretty soon. So yeah, there's that. And then just for anyone, this was already referenced a little bit, who's unfamiliar, we rebranded last summer. So if you're wondering who Smart on X is, we were Smart Denture Conversions. It's the same company, it's the same people, it's the same ownership. It's really just a new name to accommodate new product lines. We were Smart Denture Conversions, which really is, one product line. We wanted to do things like the Omnibut, so we needed a brand that could accommodate that. So Smart Denture Conversions still exists, still the same group of people. It's just now a product line underneath our larger brand of Smart on X. And we did give it a little refresh, the logo and all that. So before we get started, we want to ask 2 quick poll questions, kind of to help Dr. Kofer gauge his understanding about the audience who's here tonight. And so I'm going to launch this right now, and you can see the 2 questions here. How many arches are you doing per year? And what is your preferred surgical protocol for full arch fixed? So I'm going to launch this right now and give you about 30 seconds to a minute to answer. You should see that pop up on your screen. And there's 2 questions there. So please answer both of them to help us better understand, the level of your experience. And we are more than happy if you say none. If you're not that feeling super experienced in full arch, that's okay. We really we're here to educate and have a good time. Okay.
Need some Jeopardy music. Do 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 do
So
do do do.
we've had about 64% participation. Give you guys a little more time to fill it out, and then we'll end the poll and get a move on here. So give you guys, I don't know, about 10 more seconds or so. All right, I'm going to count it down here. So 5, 4, 3, 2, and 1. And I will end the poll. And I'm going to, share those results with everybody. All right. So it looks like most of you have some experience with full arch fix. That's great. So about 50% of you are, doing some amount of full arch fix. That's awesome. And then I don't know, any results surprise you here, Dr. Koford?
Yeah, I'm surprised we don't have 100% preferring freehand with Smart Denture Conversions. We're gonna have to work hard to get that.
Fair point. Okay. Well, I'll let you take it from here, Dr. Koford.
Perfect. Appreciate it. Thank you, Cameron. All right, and once again, it's awesome to be here. We are here to discuss the new multi-unit abutment that you've all probably heard me talking about for years now. We finally got it approved through the FDA in January of this year. So it was a Herculean effort to get it through the FDA, us being a small company and all, but we finally did it. It was awesome. I have been using it for a couple years now, and I love this abutment because of what it allows me to do clinically. So this was not an easy thing to do. Smart Denture Conversions was a pretty easy product for us to get through to the market. But so just me and Charles were able to do that. But the Omnibut required a little more help. So we added 2 additional engineers to help us through that, a mechanical engineer and a biomedical engineer. And it's taken us about 4 years just through development, testing, and FDA approval process. So we're excited where we are. But for those of you who don't know the story behind the development of the Omnibut, let me just share it briefly. I worked with an oral surgeon a lot on a lot of cases, and we had one particular case that was a vertical maxillary excess case. We were going to be chopping off a lot of bone. That is a technical term, chopping off bone. Just kidding. And we were going to lose a lot of cortical bone. So I always worry about not having primary stability. So I asked for 8 implants. and it was a very narrow ridge, so we were going to be using 3.5 millimeter implants. That's another reason why I wanted to increase the number of implants than we typically would have placed. So he lost count and he placed 9 implants. Before the procedure, our Strawman rep wanted us to try BLX. And so we said, we'll try it, but you need to provide all of the parts. Well, my part begins once the implants are in and we know they're stable, we know we're going to be loading it. I get behind the patient, I start calling out my multi-unit abutments. So I get behind the patient, I start calling out 30, 30, 30, 30, 30, 30, 30, 30 straight. And silence from my sales rep. I look up and I ask, hey, Mitch, what's up? And he says, I have 2 17s and the rest are straight. Oh. So luckily, doing smart edge conversions, I knew that I wasn't going to have a path of draw issue. So that wasn't a concern. I knew the holes would be coming out, the aesthetic surfaces of the restoration, but they'd at least be small enough for me to cover. So I went ahead with the smart edge conversions and went to the next room and I started doing my conversion. And meanwhile, my assistant Ray, whom many of you know, started talking to me saying, hey, Doc, don't you think it'd be cool if with one abutment you could do any angle you wanted to? And, I'm in the thick of it and I'm frustrated and I just wasn't listening to him. I'm like, shut up, Ray. You don't know what you're talking about. Right. That'll never work. Blah, blah, blah. So just kind of ignored it. Well, a couple months later, Charles was in the office with his mom. His mom needed a denture reline. And so she's in operatory 2. I'm in operatory 1, working with Ray, just placing retraction cord or something like that. And Ray says, oh, can I go talk to Charles about my idea? And I was like, what idea? And he said, the abutment. And I said, oh, whatever, go for it. So he goes to the next room and he's talking to Charles about it. And I'm listening while I'm just placing retraction cord because it's boring. And I start understanding what he's talking about. And so I deglove, get up out of my chair, and I go over to Op2 and I say to Charles, that's actually a really good idea. That would be amazing. And so it was that clinical scenario that led to the development of the Omnibut. So now we have another poll here I want to ask, just getting your familiarity with multi-unit abutments, right? So there are 2 questions here. When using MUAs, multi-unit abutments, what is your objective? And then what do you see as the biggest limitation to the conventional multi-unit abutments? So Cameron, if you could go ahead and launch that poll.
Just launched it.
All right, so we'll give you about a minute to answer those questions. So when using multi-unit abutments, what is your objective? What is your understanding of what you're really trying to achieve there? Is it paralleling your temp cylinders? Is it using, you just have a formula. I do a 30 in the posteriors and a straights in the anteriors. Or are you like, listen, I only use straights? Or are you of the school of thought that you're using the multi-unit abutment to direct your screw channels into the cingulum of the anteriors and the occlusal table of the posteriors? So based off of what your objectives are, then what is the biggest limitation for you to achieve your objective with the conventional multi-unit abutment? Is it the limitation of the angle correction? Is it, to a straight 17 or 30 degree angle correction? Is it the hex of the implant that is the biggest limitation? Is it the prosthetic screw channel is partially cut away for the abutment screw and you're like, that's why these prosthetic screws loosen? Is it because of how bulky the multi-unit abutment is? And so you see gingival recession around the bulky part of the abutment. Are they frustrating for you to place? Or have you just given up on multi-unit abutments altogether and said, I'm only using locator fixed because it's going to be easier? Or are you of the opinion that they're absolutely perfect? So Cameron, do we have enough to move on?
Yeah, we got about 57% people who've participated. If anyone wants to participate, now is your chance. Speak now or forever hold your peace. So let's count this down. I'll give you about 10 seconds here. All right. 5, 4, 3, 2, and 1. Okay. I'm going to share the results.
Awesome. So I see that there are a lot of alumni from my training program here. Directing the screw channel into the cingulum of the anteriors and the occlusal table of the posteriors will lead to the sleekest prostheses possible, and just having the best intaglio contour. So I like seeing that. Now, the old school of thought was to parallel your temporary cylinders for a conventional conversion so that you'd have a common path of draw that wouldn't completely obliterate the denture. So the problem with paralleling temp cylinders is it can lead to concave contours in the intaglio. So those who only use straights, you're going to love the Omnibut. Those who want to either parallel or direct the screw channel into the cingulum of the anteriors and the occlusal table of the posteriors, you're going to love the Omnibut. Especially if you feel like the limitation of the 0, 17, and 30, which is about 59% of you, is your biggest limitation, or the hex of the implant, you are going to love the Omnibut. Can we close this and
Yep.
Awesome. All right. So what is the Omnibut? It is an abutment that you'll be able to correct the angulation from 0 to 30 degrees and everywhere in between. So it goes in as easy as a straight, and then you can just move it wherever you want to. Okay, here's another little video clip of. So it just from 0 to 30 degrees and everywhere in between, and it's independent of the hex. So it's made out of grade 23 titanium. It's a strong titanium alloy. It is not a ball abutment, but there is a ball, right? So it's a ball and socket type joint. And so the ball abutment gets screwed into the implant, and then the swiveling base is what allows you to change it however you want it. And then there's an orientation screw that locks that position into place. This is not for single units. It's not for 2-unit restorations. It is only for 4 or more implants. It's really 3 or more, but we say 4 or more implants. And the reason why is if you have 1 implant, with enough force, you'll be able to overcome that locking mechanism and displace at 360 degrees. If you're on 2 implants, then you'll be able to displace it 180 degrees. If you're on 3 implants or more, you've created a plane. There's no axis of rotation, so it cannot move. So, like I said, it's a ball and socket joint. There's an orientation screw that keeps it positioned properly. And so this is a little animation that shows how it works. You have a driver that goes into the ball, and that's what allows you to torque it to 30 Newton centimeters or 35 Newton centimeters. And then the orientation screw, you can loosen it, move it, and then tighten it down. And then we have these orientation posts that allow you to visualize where your screw channel is going to be, right? And so those of you who have taken my course, you know that I just say, point your screw channel to the opposing plunging cusp, and that will put your screw channel right dead center in the occlusal table of your restoration. And in the anterior, you direct it to the cingulum of the opposing, and you're pretty much on. You know, there's a little variation in the maxillary versus the mandible, but pretty much. All right. So you do have to just follow your implant system's torque recommendations. So we have these for Noble Active, a conical connection, Neodent Grand Morse taper, the Straumann BLX, and the Zimmer tapered screw vent, which is also the BioHorizons connection. So this orientation screw, you can loosen it, pivot it, and then tighten it. And it uses a T6 driver. T6 stands for Torx 6, and it is also the Straumann driver. So here you see how you use that T6 driver to just upright it and then tighten it down. Once you've done that, you've tightened it by hand, we add these, they're called orientation posts, and this will allow you to fine tune it to exactly where you want it. So if you're trying to go for parallel, super easy to achieve this. Although my recommendation with smart edge conversions is to direct your screw channel into the occlusal table of the posteriors and the cingulum of the anteriors. So once you've got them positioned, you just provisionalize however you prefer to provisionalize. So if you're doing a stackable guide, great, you would proceed with your stackable guide prosthesis fabrication. If you're doing smart edge conversions, great, you proceed with smart edge conversions. If you're doing a conventional conversion, I don't know why you would choose to do that, but you would just carry on with your conventional conversion. Now, one question that people ask is, aren't you worried about it moving? And so how does it stay in place? How rigid is that connection of the swivel base to the ball? And then isn't the prosthesis going to move because you're on this swiveling component? What about micro movements? Aren't you worried about micro movements and how it might impact the healing of the implants? And then will the omnibuts move after you remove the prosthesis? So the short answer to all those questions is no. The connection of the swivel base to the ball is not flimsy. It's not floppy. It's rigid. It has a built-in resistance to rotation, right? So you'll see in a subsequent video here that even if you have you haven't tightened the orientation screw at all, the omnibut won't pivot. It won't move. It takes a little bit of force to move it. That's just the baseline tightness of that swivel base to the abutment to the ball. So you can see here with that orientation screw loose, it doesn't just flop around, right? It holds its position. It needs a force to move it into position. And then you can also see it, once you've tightened it, you can move it, but we haven't torqued these down yet. We just tightened them by hand. So once you've got the orientation set, once you've got the abutment oriented how you want it, then you just set it with that orientation screw. Now here's that video I was telling you about. You can see with one abutment, you'd have 360 degrees of rotation under force. With two under force, you could displace it 180 degrees because you have an axis of rotation. But do you see how there's that built-in resistance to movement? And then with three engaged, you can't move it. You don't have an axis of rotation. It's a plane, and by definition, a plane has no axis of rotation. So on 3 or 4 or more implants, that prosthesis will not be pivoting at all. The abutment, it's titanium on titanium, so there's no give. And so once you've got all 3 or 4 of those implants connected, there's no micro movement because you are metal on metal. So the laws of geometry just don't allow for any of this movement. And then micro movements, we tested this compared to the standard multi-unit abutment because we had to prove to the FDA that what we were saying was true. So we loaded this setup with a standard multi-unit abutment and then with the Omnibut, and we did it to 5 million cycles at that cantilever. And so it's pressing down, and you would think that there might be movement going up and down, tipping on that, but there's not. And here you can see a graph of those results. And so that the parallel nature of that graph just shows that there's no movement. So when you remove the prosthesis, if the orientation screws have loosened, then yeah, the omnibuts could move, but there's that built-in resistance to rotation, and so they don't. And we tested the loosening of the screws under that fatigue cycle, and they just don't move. So here you see the position of those abutments before we did the dynamic fatigue testing. Here they are after the dynamic fatigue testing, and they haven't moved. They are they hold their position, and it's mostly because that prosthesis just doesn't allow for any kind of movement. So if you do remove the prosthesis and they are loosened, then that's not a problem. But according to this test, we don't expect that to be a problem, and clinically, I haven't observed it to be a problem. Will a patient be able to move it at all, or will they be able to detect any movement? No. Even if like you remove the prosthesis and the patient's real curious and they're like playing with it with their fingers or their tongue, the abutment is not going to move. So now, what if it does move when you remove the prosthesis? So here's a simulation of the prosthesis removed and the abutments were loose, and so we just upright them, get them in a rough position, and then the prosthesis itself is the reseating jig. So the abutments just reorient to the prosthesis, and then through the prosthesis, you can engage that locking mechanism to tighten it back, and then put your prosthetic screws in and tighten it down. And there was some question about, well, will it really be passive? Well, we tested that. And so here we cross-sectioned a prosthesis that had been, so I made a model with implants, I placed abutments, I made a prosthesis, and then I removed the abutments, I shook them in my hand, I placed them in random implants in the model, put the prosthesis back on, they reoriented, I screwed it down, and then I embedded that in acrylic, and then I cross-sectioned it. And in this cross-sectioning here, you can see that the metal tie base is resting right on that abutment shoulder. So that is, as by definition, that is a passive prosthesis. What the concern that most people have about this non-indexed part, it's a non-hex part, is if it loosens, you'll never be able to reorient it to the prosthesis. And that's true of other abutments, but it's not true of the Omnibut. The reason why it doesn't work for other abutments is the abutment screw has to be tightened down. But that abutment screw is not accessible with the prosthesis in place. Here you see a typical multi-unit abutment, and you see that the prosthetic screw and the abutment screw are not in line with each other. And that abutment screw is what holds the abutment's position for the prosthesis. But with the Omnibut, the part that holds the abutment, the abutment's position with the prosthesis is in line with the prosthetic screw channel. So if it ever does loosen, you can access the locking mechanism through the prosthesis. So that's a huge distinct difference between a standard multi-unit abutment that is non-engaging and the Omnibut, which is non-engaging. All right, so here you can see that the abutment in the implant, that ball in the implant, that's not moving. What's moving is the swivel base around the ball, and that orientation screw, that locking mechanism, is accessible through the prosthesis. So the other question we get is, well, aren't you worried about this abutment breaking? And we had to prove that to the FDA as well. So we took it through what's called a 14801 test. And that's a fatigue cycle. You have to have 4 that pass over 5 million cycles and 4 that fail under 5 million cycles. And that helps you kind of zero in on what is the strength and the fatigue point of this abutment. So let's just show you. This is what the test looks like. So you have it set at 10 degrees beyond what it's meant to correct. So this is set at 40 degrees. And you just load that abutment for over 5 million cycles. And you're trying to see what fatigues. What's interesting is the FDA is accustomed to seeing a certain data point, and our abutment lasted or survived twice the value of what the FDA is expecting to see. And so we are very, very confident in the strength of this abutment. So here you see the minimum acceptable load that the FDA is accustomed to seeing. So for like a 3.5 diameter implant, they'd expect to see like 170. And so they didn't tell us this, but we exceeded the minimum acceptable load by twice, by double. But what's interesting, and anybody who's ever heard me lecture, they know that I am a big believer that everything fails. Everything. And I've seen it. I think I've seen it all, right? And in this one picture, this is one of my favorite pictures because it shows the various types of failures. So we had implants fail to integrate, and that's why this prosthesis was sectioned the way it was. And then it was used to support a removable partial denture on the patient's right side. And this is not how these implants and abutments were designed to function. And so they overloaded the system. And the first failure here was a prosthetic screw failure on the most distal implant. So now you have the two anterior implants here holding all the load. And so the second failure was the abutment screw failed deep down into the implant. And so now you have one implant holding this whole gargantuan system of a prosthesis, and the implant itself failed. So this is kind of what the FDA is interested in simulating in that the 14801 test. All right, so here you see that whole huge system and why this failed. The implant fracture is non-restorable. That has to come out. The abutment failure with the threads deep down in the implant, that can also be non-restorable if you can't retrieve the threads from deep down in the implant. So I always tell people, if I'm going to have a failure, I don't want it to be the implant. I don't want it to be the prosthesis. I'd rather it be the abutment. But if the abutment's going to break, I want it to break high superficial in the implant so that it's easier to retrieve. So these are just a few examples of implant component and implant failure in my practice. These aren't implants that I have placed, but this is just what comes through my practice. And then here you see a Bicon implant where the screw broke right at the top of the implant, and we were able to retrieve that. You also see stripped screws. You see broken tie bases stuck in the implant. Here I have a case that was referred to me where they broke the abutment screw, and it was down deep in the implant. They sent it to me to try to retrieve it. We tried to retrieve it. We drilled through it, and I was able to engage it with my screw retractor. And I was trying to retract it, and the screw retractor tip broke in the implant, and that's impossible to remove. So we ended up removing the implant and placing a new implant. So failure happens, and you want to control the failure. You want it to happen in a very easy and predictable way to retrieve. So when the Omnibut did exceed, or when the forces did exceed the Omnibut, the nice thing is we know exactly where the Omnibut's going to break, and it's super predictable to retrieve. Additional FDA testing was, the retaining force of that swivel component on the ball, cytotoxicity, sterilization, validation, the simulated all-on-4 test that we did to prove that it doesn't move under force in an indicated use, implant compatibility, and patient hygiene test. So just another concern people have when they look at the abutment in like a corrected position. in like a 30-degree orientation. They're like, is that even cleansable? The key to cleansability is making your prosthesis cleansable. So anybody who's taken my course, you know that I harp on cleansable contours. If the intaglio is cleansable, then the abutment is cleansable. If you have flanges, if you have concavities that cover access of a floss or a bristle brush or a water pick to the abutment, then the abutment is not cleansable, regardless of what the abutment is. Here you just see a couple examples of, you know, the detriment that we give to our patients when we don't give them cleansable contours. It is our responsibility as clinicians to make the contours of the prosthesis cleansable. If the contours of the prosthesis are not cleansable, then the abutments are not cleansable. All right. So this is what we had to do for the FDA. We had to come up with like a worst case scenario, and we thought, okay, well, worst case scenario is we have a small gap that allows for food and debris to get stuck underneath the prosthesis. And so let's use a occlude, which is a very messy substrate. Let's use a occlude to just pretend or simulate debris, and then we'll brush, floss, water pick, mouth rinse, and see if it's cleansable. So we had to do this for the standard multi-unit abutment and the Omnibut. So here you see us doing the various patient hygiene practices, floss and interproximal brushes. And the results are, if the prosthesis is cleansable, the abutment is cleansable. So Omnibut compatibility, a lot of people have expressed a lot of excitement about the abutment, and they're like, oh, I use Neodent? Is it compatible with Neodent? Yes, we're compatible with Neodent. We're compatible with Nobel conical connections, narrow and regular platform. We're compatible with the Straumann BLX platform and the Zimmer internal hex platforms, which is also going to be your BioHorizons. So for affordable, Neodent and BioHorizons internal hex platforms were compatible. So here you see the compatibility and what they look like. And we're currently working on additional 510(k) applications for other compatibilities. I don't think we necessarily need to do this. So one major change that we had to make to the abutment is we did have to go with a slightly larger diameter prosthetic screw. That is because we needed the driver that engages the ball abutment to be strong enough to be able to do 30 Newton centimeters without breaking or distorting. And so we had to open up the screw channel to allow for a driver of substantial dimension to engage that drive feature in the ball abutment. And then we also had to make the threads a little finer so that we wouldn't have to cut out any of the threads for the driver to go and engage the ball abutment. So it is not an M1.4, it's an M1.6. It's an M1.6 with a 0.2 thread pitch. It was a functional necessity. For those of you who are freaking out right now about your M1.4, don't worry. We do have in development an M1.4 compatible abutment. It's not as convenient as this current offering, but for those of you who are panicking, you don't have to panic. We have something coming soon. All right, now this is the most exciting part to me. This is what gets me excited every day, is just what can we do for our patients. And so I started using the Omnibut back in 2022. And I took this patient, this was patient number 1, where I took her from a mandibular overdenture on 7 implants. And then I put the Omnibuts in place and have followed her through, and just everything is looking so beautiful. And it was so easy to convert from a removable appliance to fixed, and not having to worry about the timing of the implant is just awesome. So that was patient number 1. Here's a patient where I did it with a guided protocol. And, it's pretty much just a screw retained restoration once you get the abutments in place. And you can just see the bone levels of the bone around the abutments and around the implants. They don't really seem to move much. This was another guided case, and she's had these abutments since 2023, and everything is just looking great. So 2023 to 2024, this is about a year follow-up here. And 2023 to 2024, November to August, so just under a year here. And so this just, I like to put this sequence of panoramics in place because some people are concerned that you'll never get to a final restoration because the abutments will move and they won't be passive and you will blah, 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 blah. No, that's not true because the prosthesis itself is an orientation jig. And you can also see just how well the prosthetics fit onto those abutments. So here's a year follow-up for this particular case. And just about a year and a half on this case here. About, what is that, about a year and 3 months, 2 months here.
Well, and I appreciate that you're showing this, Dr. Koford, because it shows the development as well and the time that we spent in developing the Omnibut and getting it right and making sure it was tested and ideal for and ready for customers.
Yeah, absolutely. This has been in development a long time. We have worked out the clinical protocol that I think is very, very uh, it makes it very easy clinically. Now, this case I love. This is October 2024 and March 2025 when I delivered the zirconia prosthesis. So this just proves my point that the locking mechanism is not necessary. It's a clinical convenience, but it is not a functional necessity. Because if you look close at those abutments, this is our version of the Omnibut that doesn't have an orientation screw. There's no locking mechanism in this version of the abutment. So the prosthesis holds its position and then the prosthesis reorients the abutments, no problem. Now, what does the Omnibut mean for my practice? I don't have to compromise on angulation anymore. I can get exactly what I want, and I'm shooting for the cingulum of the anterior and the occlusal table of the posterior. And there's very easy ways to get there. The timing of the implant is not an issue. I get more efficient MUA placement. Just a quick story. I just did one of my courses this weekend for affordable. And there were some inexperienced users or inexperienced full arch clinicians in the group. They were wonderful, but they were inexperienced. And I train how to place multi-unit abutments, how to select them, how to place them, and how to use them. And we did 2 arches, and it took like 35, 45 minutes to get the abutments selected before we could move on to the provisional. For the 3rd arch that day, I let them use the Omnibut. It took them 1 minute and 30 seconds to get their abutments in place and proceed to do the pickup. It was just incredibly more efficient. 2 weeks ago, I went to Arizona to help an oral surgeon and prosthodontist learn the Omnibut. And the surgeon spent a lot of time on the maxillary arch trying to get the implants timed just right. And I looked at him and I said, "What are you doing? You're wasting your time." He says, "No, no, no." And then he was using the try-in multi-unit abutment guides. And I said, "You are wasting your time." And he said, "No, no, no, I want to make sure that I have the abutment, the implant positioned properly for the abutment, blah, blah, blah." And I said, "No, you're using the Omnibut. So the timing of the implant doesn't matter. And it doesn't matter if you don't have to choose a straight 17 or 30. Just place the implant, get it stable, and then we'll screw it in." So for the mandibular arch, after he understood that, as soon as he had the bone reduced, I said, "Stop, I'm going to time you. I'm going to time you from the time you first drill your first osteotomy until the time you're ready to suture." And so he was placing 4 implants. We started the clock. He drilled his osteotomies. He placed his implants. He placed the abutments. He redirected the abutments, and he put healing caps on top of the abutments instead of tie bases. But he put healing caps in place, and then he sutured up. It took him less than 15 minutes to get his osteotomies drilled, his implants in place, his abutments in place, and start suturing. That's pretty amazing efficiency, and that's what the Omnibut really brings. It also brings a simplified inventory management. So remember that case that inspired the Omnibut? Oh, I needed 9 or 8 30-degree multi-unit abutments and 1 straight, but I only had what was that, 7 straights and 2 17s. That's an inventory management problem, and we've all been there. So the Omnibut makes it so that there's just one abutment. It'll do it all. And then if at the time of surgery you select one angulation, and then to get to the final restoration, you need to select a different angulation, it's not replacing the whole abutment, it's just pivoting to a new position. So it's a pretty awesome simplified approach. Cameron, I'm going to let you take over here. I think I've been talking a lot, so go ahead.
Yeah, so thank you, first of all, Dr. Coford. We are going to take your guys' questions here in just a bit. I know one of the big questions we get is, obviously, what does the Omnibut cost? If any of you have been surfing our website, you can go to the next slide, Dr. Coford. You'll see that it is $150, but for affordable practices, it is $75. Now, there's also exclusive pricing, not only just for the Omnibut, but for all of the accessories and everything that comes with it. You'll see all that pricing in Dentira. We've obviously loved working with affordable practices, and we want to make sure that we continue to serve you. So yes, we are offering it at a pretty steep discount. You'll also see that we have this list here of everything that you need to really get started. Obviously, there's the Omnibut, and Dr. Coford's talked about the orientation posts and the orientation screws. Obviously, we have a different prosthetic screw, and there's healing caps, drivers, all of those things. If you go on our website, you'll see we do have a bundle that offers these things that currently is not in the Dentira system, but we will send out a list with all of these things that all of these products are in the system. And we can send you this list to make sure that you get everything you need if you want to get up and running with Omnibut quickly. To that point, if you are, struggling to wrap your head around it all, we do have an evaluation kit. And this evaluation kit is designed to let you get your hands-on with the Omnibut. So you can see everything in that picture is what we have in our evaluation kit. And what this is you come to our website, you spend $150, and it's a deposit that allows us to ship this out, send it to you for 2 weeks, and we ask you to ship it back. And the Omnibuts come in that stone model. It's already in place. It's already torqued in and ready to go. You can take it all apart, play with it, see how it works, and see that you can truly put everything back in place. And you can use the denture as a verification jig. You can do all of the things you want to do with it, and really feel comfortable with the Omnibut before you dive in using it with a patient.
And then as you return it, the $150 deposit gets returned.
Yep. So there's that. Now, obviously, this works seamlessly, the Omnibut, with smart denture conversions. And so we know many of you are already familiar with that. We have Omnibut compatible kits, meaning smart denture conversion kits, our premium starter kit, our recharge kit that have Omnibut compatible parts. So you can find those, and those are already available to you. Okay, so we have one last poll here for you, and we want to know, what is the biggest challenge you face with full arch fixed? We have a bunch of options here, so I'm going to launch this right now, and you'll see that we have a lot of options for you to look through. We have, yeah, sorry. I was wondering if there's a single question or multiple questions, but we're asking you to give us the one thing that is most difficult for you. We're very curious. Obviously, our goal at Smart on X is to make all on X easier, to do it smarter. So we're trying to find what are the biggest issues people are facing and how we can address them. And so uh, getting your feedback on this helps us to know how to help you. Okay, we got about 50% of you. I know that's a long list to read through, and that some of them are a little longer than others. But part of me is proud and part of me is sad that the last answer, I mean, I don't know if I don't think you guys can see it yet, but hasn't been filled in. So so give you about 20 more seconds here. Okay, 10 more seconds. Get that answer in. 5, 4, 3, 2, and 1. I'm going to end the poll. And I will share those results so all of you can see. So we got a kind of a spectrum of answers here. Anything surprise you, Dr. Covered?
No, that multi-unit abutment selection is the most, followed by the managing restorative complications. Yeah, I agree. So most people will say the surgery's easy. It's the restorative that makes it challenging. And the multi-unit abutment selection is one of the biggest trap challenges. And the Omnibut just makes that so much easier. I can't wait for you guys to experience it. Now, like anything, there's a learning curve, right? So um, you just have to learn it. And once you learn the nuances, it's a piece of cake. Dr. Fenton, sorry for going over.
No, you didn't lose one participant. It was great. And it falls right along the lines of just the evidence-based dentistry and the data-driven case study and due diligence that we all find of value, right? And I know all the docs on the line appreciate that. So again, rather than an endorsement or plug, this was really intended to give these docs the firsthand knowledge of knowing what's out there. Not much of telling them what to use, but just allowing everyone to understand that there's a cool new tool and component out there, and they're absolutely welcome to try it. So again, just to reiterate, Dr. Koford is on staff with us in regards to being a key opinion leader. He teaches both the provisional fixed full arch course as well as the final restoration fixed full arch course. I highly encourage you to attend both of these if you haven't already, or if you've dived into fixed full arch reconstruction. The next fixed arch provisional course is this August at the end of the month, and then he's got the final course in October. So we offer each of them twice a year, totaling 4. And again, just with the notion of implant dentistry being restoratively driven, and the poll results that you saw, right? Like the restorability aspect is just crucial. So I just want to make sure that everyone gets their questions answered. I'm going to go in order here for the most part. I'll kill 2 birds with 1 stone. There are some questions, Brandon, around prosthetic space, right? Which is defined as crest of bone to incisal edge. And the question was wanting to know if there was a different or unique consideration that we need to keep in mind with the Omnibut in regards to prosthetic space. Do the implants need to be buried any deeper? What's your perspective on crestal placement, subcrestal placement, supracrestal placement? We know that the minimum, prosthetic space for zirconia full arch restoration is 12. However, the sweet spot, is more like 15. The strength comes with the bulk of the material. So that was 2 of the questions that you'll be able to knock out with that answer.
Yeah, so that's a great question. And uh, there are different schools of thought with the placement of implants subcrestal. My training has always been with the implants being pretty much at the crest or slightly subcrestal, like a 0.5 millimeter. So this first iteration of the Omnibut was with that mentality. And so from the implant platform to the restorative platform of the abutment, it's in its straight orientation, it's 2.3 millimeters. So I have found that that 2.3 millimeters is the ideal height for for getting through the transmucosal component of the abutment, right? So there's no real additional restorative space required for the Omnibut. It really is just like any other multi-unit abutment at that point. However, I do have friends who insist on placing neodent implants subcrestal, substantially subcrestal. And so we have currently in development, and it should have an FDA clearance by the end of the year, a taller Omnibut that accommodates a subcrestal placement of neodent implants. But the idea is to get that, even with a subcrestal placement of the implant, you still want to have that restorative platform between either equigingival or subgingival by a 0.5 millimeter. And so it doesn't require any additional restorative space for the prosthesis. Did I answer both questions?
Yeah, I think so, Doc. Thank you. Dr. Clear's got a question. Should the abutment need to replace secondary to failure, et cetera? How easily can the MUAs be realigned with the implant interface of the existing restoration?
So if I understand the question correctly, if I have to remove an abutment and place a new abutment in the same implant, how easily will the new abutment align to the old prosthesis? Very easily. And that's one of the reasons why we have that that demonstration kit available. We actually encourage everybody to take all of the abutments out of the implants, shake them up in your hand so you know that they're not going into the same implant, put them into the implants, and then see that the prosthesis will reorient the abutment. Now, one thing that's a lot of people don't understand is this abutment does not allow you to have a failed implant and then place the implant in a new angulation and then have the abutment fit an old restoration. That would be almost impossible to achieve. So if the question is, how do you replace an abutment into the same implant? So you have a new abutment in an old implant with an old prosthesis, very easy to realign the abutment to that prosthesis.
Thanks, Doc. How is this connection in regard to the neck of the implant seemingly narrow? So that's where the question ended. I guess I could expand on it by asking, hygienically, right? Radiographically speaking, it looks like a potential, undercut or food trap in which the neck is narrow, right? And then it flares out in that, flowered shape. So perhaps you could comment on that. The other way I would interpret that is, from a strength, right, or a flexural question. Since the neck is narrower, have you seen or been exposed to any type of fracture secondary to occlusal load?
So I have, in all honesty, I've had one patient break 2 of the abutments that I made myself. And the reason why they broke is because I put a stress concentrator in the neck and he broke it in the provisional phase. And so, I just retrieved the fragment out of the implant and then replaced it with new abutments that didn't have the same stress concentrator in the neck that I had put in it myself. So of the, over 50 or 100 arches, I don't know where I am right now, but that's been the one instance of any kind of fracture of the abutment. And that was, it's because of how I made the abutment. I put a stress concentrator in there inadvertently, but I put it in there and that's what led to the early failure. The all-on-4 test that we did was to test if the abutments are used in an all-on-4 or all-on-X protocol of 4 or more implants, then you will not experience an overload of that abutment likely. If you lose implants and now you go from an all on 4 to an all on 3 to an all on 2 to all, that's when things start to fail, and that's predictable. But if it's an all on 4 or more, then it's very, very strong. As far as hygienic goes, the conical connection for implants is proven to be better for bone health than the butt joint. And the reason is because of platform switching. Platform switching is bringing that biologic insult to the bone and the implant bone interface as far away from the bone implant interface as possible. So this is kind of like platform switching on steroids. And if you make the prosthesis cleansable, then flossing and water picking and toothbrushing or interproxy brushing, that will clear out the debris and clean that neck very nicely. It kind of directs the bristles into the areas that need to be cleaned. So I actually have noticed that the tissue is a lot healthier around the Omnibut than it is around the standard multi-unit abutments that are pretty bulky. And so I see induced gingival recession around the long wall of the multi-unit abutments all the time that I just don't see with the Omnibut. So I've been very impressed with the soft tissue response to the Omnibut.
Thanks, Doc. Dr. Musashi asked when is it next CE course? So we kind of announced it already, Doc. You can also look on the Inside of Affordable page on the Clinical HQ. The live course calendar is there. So you can easily just kind of cross-reference that with when his next course is going to be. But like I said earlier, one is in August and then one is in October. Dr. Cleary is asking, can you restore direct to zirconia without use of the titanium, the tie base?
Yeah. In fact, so I have this case right here that I'll be delivering on Friday that is direct to Omnibut with no tie base.
And tell me what you think, says Dr. Dawson. Doc, like I like you all, your proficiency comes with trying things out, right? And that's going to help you formulate the best opinion. There's things that work well in some of our hands that others prefer differently. So I would just encourage you to try it. Right? It's a very unique concept. It makes a lot of sense for a lot of reasons, but at the end of the day, it's going to be what works well in your hands. So it'd be hard for me to comment on it yet without personally doing a case, but I'm certainly open to doing so. And I think there's a lot on this call that will also be open to doing so as well. Dr. Bohm asked about abutment heights available.
Yeah, so like I said, right now we just have the one height that in its straight orientation is a 2.3 millimeter tissue height. And so I'm a big believer that these cases really ought to have the bone planed. And so if you do that, it's always predictable what tissue height you need for your abutments, and you can control the tissue surgically. We do have a taller abutment that in its 30-degree orientation will be 2.5 millimeters. So in its straight orientation, I want to say it's 3.8 millimeters in height. And so that's for the subcrestal placement of the implants. And you just have that running room to get out of that subcrestal position to a good gingival position. That will be available towards the end of the year.
Thanks, Doc. Next question. How many times can you remove the abutment or adjust the angulation before you have to use a new abutment? And I'll actually piggyback off that one too in regards to the screw, right? That locking screw. I know that, with prosthetic screws, the literature really points towards changing it out every time you replace one. So what is the protocol for using a new abutment after it's removed several times and or the screw that comes with it?
Yeah, so I don't recommend that you remove the abutments ever. You want to keep that implant sealed off, right? So actual removal of the abutment is not recommended. Reorienting the abutment and using the orientation screw, we don't have any set number of how frequently you can remove it, or sorry, reorient it and torque it. Um, I retorque it after every removal of the prosthesis. I just put my driver through the prosthesis and make sure it's locked at 25 Newton centimeters. Um, as far as the prosthetic screw goes, it's an M 1.6 millimeter screw, so it's a beefier screw than the traditional multi-unit abutment screw. Um, it has 360-degree engagement, unlike the standard multi-unit abutments that have that window cut out of the prosthetic screw channel. So you might get one or two threads with 360 degrees. Otherwise, in that window, you've got the prosthetic screw threads cut out, so you don't have 360 the full length of the screw. Whereas with this abutment, you do. So screw loosening has not been an issue for us. And I reuse my prosthetic screws. You're only torquing those prosthetic screws to 15 Newton centimeters when they could be torqued to 30 Newton centimeters, because that's what the typical abutment screw would be. Like a Nobel abutment screw is 1.6 millimeters in diameter.
Okay. I think I may be able to package the next three questions into one because there's some correlation between Dr. Dawson, Dr. Bazzaretti, and Dr. Clear. So wanting to know what the limitations are, if you've experienced any, if there's any outside of your traditional, surgery patient that's just not, either ASA classified appropriately, the patient with abnormal or excessive parafunctional habits, right? Like all the traditional contraindications that we're using for conventional screw retain and multi-units, are there any limitations specific to Omnibut? And one of which is being, the largest angle that you've ever tried, or what is the largest angle that it caps out at? And then in relation to angles, zygomatic / pterygoid implants of remote anchorage, do these apply, and can they be used for those type of exotic fixtures?
Yeah, so I personally haven't restored any zygomatic implants. I have pterygoid implants. And I mean that I haven't restored them with the Omnibut. Not because I'm opposed to it, just I've been waiting for, most of my zygomatic implants are external hex. And so we're making an external hex Omnibut. So I've just been waiting for that availability. The limitations of the Omnibut, I can't think of anything that I'd say that there's a unique indication for conventional multi-unit abutment that I wouldn't recommend for the Omnibut. Remember, we had to go to the FDA to prove that this abutment is substantially equivalent to the Nobel multi-unit abutment. And so the data that we provided to the FDA gave them the data that they needed in order for us to claim substantial equivalence to a multi-unit abutment. The largest angle that I've ever corrected is 30 degrees, because this is an abutment that goes from 0 to 30 degrees. It can't go more than that. So although I might have implants that are placed at 45 degrees, the most I can correct is 30 degrees. And so it'll just have a prosthetic implication to not correcting the additional 15 degrees, but that hasn't been an issue for me. So yeah, I haven't found any contraindicated Omnibut versus multi-unit abutment.
Thanks, Doc. I think I got just one more from Dr. Delbert. He was asking if there is any change to protocols for verification jigs, and if so, what would those be?
So that's one of the things I love about the Omnibut is getting a passive prosthesis is pretty easy. You can do the verification jigs the standard way, but just remember you'd have to use an impression coping that allows for the Omnibut prosthetic screw, or use the Omnibut impression coping. Or you could do a digital workflow. We have a digital workflow for those of you who are using photogrammetry. We have an adapter that's going to be coming out here shortly that allows you to use whatever photogrammetry you're using for a digital verification jig. I do a whole lot of just using my prosthesis, my provisional prosthesis, as my impression. So I haven't really made many conventional PVS impressions in a really, really long time. So uh, there are all kinds of ways, but no, there's nothing really super unique about the abutment other than the prosthetic screw.
Appreciate it, Doc. And I lied because there's one more. Does or should this remove the need for angled screw channels in the prosthetic?
Yeah, so I guess going back to the question about contraindications, you can use angled. Well, no, you can't, because you have to use the Omnibut prosthetic screw. So no, you can't use angle corrected screw channels. They have to be in line with your abutment. So that is one, I guess, contraindication. But the cool thing is, at the time of surgery, you might choose one position, and then to get to the final restoration, you want to change the tooth position, and that would put the screw channel in an unfavorable position. Well, you can change the position of the abutment, make your record, and then put the abutment back into the position for the provisional. And then when you get your final restoration, you can loosen the abutment, let the final prosthesis reorient the abutment to that position, tighten it, and be done. So we're kind of getting away from the need for an angle corrected screw channel, except for in the cases where you should be correcting 45 degrees, but you could only correct 30 degrees. I see that, and so we will be making an angle corrected screw shortly, but it's not available yet.
Thank you so much, Doc. Very
However,
thought-provoking.
however, we do have an M1.4 solution which would allow you to use your angle corrected screw channels with an M1.4 angle corrected screw. So there is that.
Appreciate you. I think we answered all the questions. There will be a follow-up email that will be sent out to all the attendees that will be coming from the Omnibut team. So just keep an eye out for that. Dr. Coford's a tremendously valuable resource for y'all. So he's one of the most approachable guys that we work with that's in the industry. So if you have additional questions, or if you think of anything later on, don't ever hesitate to contact him, and he'll he'll chat with you directly. But I think that's it for the Q&A, and I know we ran a little bit over, but we kept almost 100% of the audience. So they were very interested, Doc, in your component, and anything that we can use to make our dentistry better and to help improve the quality of life for our patients is a wonderful thing, right? So I think without anything else, we should be wrapping up. I'll give you guys the floor for any closing words.
No, thanks for your leadership, Dr. Fenton. You've always come to us with a very high priority on patient outcomes. So it's been very encouraging to work with you and to see your dedication to high quality dentistry, and appreciate your partnership. So thank you.
Appreciate that. Have a great night, everyone.
Thank you, everyone.
All right. Thanks for hanging in there, guys. Bye.